So let's go for this part. What are the options of treatment that we have it currently available to treat MASH with a special focus on the primary care setup?
Yes, wonderful. So putting aside there is one FDA-approved medication called resmetirom, which is it is an agonist. This is not something I'm suggesting for treatment. It is an agonist of the thyroid hormone receptor, a specific receptor called the beta receptor, which is quite exclusive to the liver. This has been FDA approved. It is effective, acting right at the liver to both reduce inflammation and even regress some levels of fibrosis. Why am I not suggesting this medication? One, it's very expensive. And then two, it actually doesn't get to the roots of the reason why the excess adiposity and the disease process is there in the first place.
Okay.
Remember, we talked earlier about if we treat obesity, don't just look at the leaves or the outcomes of excess adiposity. Get to the roots, which is appetite dysregulation leading to excess adiposity. So what we have now, FDA approved in Canada, and now just this week, Health Canada approved, is the use of the GLP-1 receptor agonist, semaglutide. Mm-hmm. We have very good evidence of the effectiveness of semaglutide in treating MASLD and MASH. In fact, it is now on label in the United States and Canada for the treatment of MASH.
Okay, excellent. Interesting. So how we can, as a primary care physician, can use the GLP-1 like semaglutide in the management of MASH and to prevent the complications of... So what is your experience in this kind of modality of treatment?
Yes, excellent. With my patient, I would start by explaining the ESSENCE trial. Mm-hmm. The ESSENCE trial is a two-part clinical trial. Phase 3, comparing semaglutide to placebo. Mm-hmm. And the phase 1 of the test, which was an interim analysis of data for 72 weeks, was looking at primary outcomes of liver health. There is a second part to the ESSENCE trial, which is event-driven. The results of this might not come until 28 or 29 or 2030. But just the first 72 weeks of the ESSENCE trial, quite a landmark clinical trial, is what I would first start to communicate as to why I am discussing semaglutide with my patient. The primary outcomes of this clinical trial were twofold. One, they were looking to the safety and effectiveness of semaglutide to do two things. One, to actually resolve MASH. Remember, we talked about MASLD, just fat in the hepatocyte. Though that is a risk factor, it is not an inflammatory disease. Mm-hmm. Can we bring MASH to where it is only MASLD and there's no longer the inflammation and ballooning? Mm-hmm. And this primary outcome, the first outcome of this ESSENCE clinical trial at 72 weeks, showed that 2/3 of patients receiving semaglutide had complete resolution of MASH. Mm-hmm. So we eliminated in 2/3 of these patients.
How long it took?
72 weeks.
72 weeks.
That was the interim first phase of the ESSENCE trial. Okay. Wow. And the second part is really also very interesting. I remember in medical school and even in the early years of practicing medicine, where we thought if the liver was fibrotic, it's too late. It's scarred. Fibrosis is like a scar. Mm-hmm. Must be permanent, we used to think.
Yes.
The other outcome in the ESSENCE trial was to look to whether that fibrosis could be regressed or lessened. So in the study were individuals with fibrosis levels of F2 and F3. Again, I set a scale of 0 to 4. So F2 and F3. And what was found was that 1/3 of all the people in the ESSENCE trial went down one stage or more of fibrosis. So fibrosis regressed in these individuals. An improvement of the liver health. And so that's where I start my conversation with patients to say, we have now diagnosed a real important medical condition that significantly increases your risk of heart disease, hepatocellular carcinoma, and even progresses to cirrhosis. This disease now is treatable. And then I suggest that semaglutide, because it is on label in Canada, I think it'll be on label in the Kingdom of Saudi Arabia soon, probably within just a few months. And then I lean in and I invite the patient to consider treatment. But keep in mind, I don't tell them I'm treating MASH. I tell them I'm treating obesity. I tell them the medication will help address appetite dysregulation. It'll help them overall eat less. And in a comprehensive obesity treatment, which is very straightforward, it will result in them losing somewhere between 15 to even 20% of their body weight. In fact, we know that in the semaglutide clinical trials at 2.4 milligrams, we know that 9 out of 10 patients lose 20% of their body weight or more.
It's a disease-modifying intervention.
Yes.
By having 20% of the weight reductions. Yeah.
Yes. So you treat obesity and then we see what happens at the liver. But you can imagine also what happens to their insulin sensitivity, to their blood pressure, maybe to their osteoarthritis that is setting in their knees.
Yeah.
Maybe they live with sleep apnea.
Absolutely.
Again, we have many complications of excess adiposity. So by treating obesity, one of the outcomes can be these most excellent resolutions in MASH or regressions in fibrosis of the liver.
Excellent. So you talk about the efficacy of semaglutide in the management of MASH. So how about the safety and the tolerability during the course of management?
It's a very good question. When I invite a patient to consider semaglutide, I often start with discussions of safety. I invite them to consider, they may not know this. People think, oh, it's a new medication? I tell them that GLP-1 receptor agonists have been on the market for 20 years now.
Okay.
We have a long compendium, millions and millions and millions and millions of patient years of GLP-1 receptor agonist medications. And so we have a very strong compendium of safety. In fact, how many people smarter than me describe it is from a safety perspective, we are now at the stage with all these millions of patients and over 20 years where your patient will not pick up their phone next month and say, oh, look at this new adverse event that they didn't know is associated with this GLP-1 receptor agonist. That will not be happening now.
Yes.
We have a well-established safety compendium because of the long-term use of this medication. And I describe the safety profile. I also describe tolerability. I review the safety of the medication. I review how to manage side effects, and there is a method that is quite straightforward how to manage side effects. I also talk to them about what to expect, what the medication is going to be treating, so they understand the symptom that I am treating.
Okay.
You see, this medication is not a weight loss medication. People think it is a weight loss medication.
It's beyond.
It's an obesity treatment, and by being an obesity treatment, it treats appetite dysregulation. I always share this bad news point with patients when I am prescribing an obesity medication. I tell them I have bad news for you. I say, normally, when you lose weight, your brain is expert at recognizing fat loss and fighting against it with increased appetite. As you lose weight, and many patients say, oh, I know this, I've experienced it. Your brain has bookmarked your highest weight.
Yeah.
As you start to lose weight, your brain will recognize fat loss specifically via lower levels of leptin. Leptin is a hormone that leaves from our fat cells. So as fat cells become less, leptin levels go lower. Our brain recognizes the fat loss and fights against it. How? With increased appetite.
Yeah.
And that's really the role of the medication.
Absolutely.
The medication defends them against the brain pushing back up so that they're able to lose, for example, 9 out of 10 patients lose 20% of their body weight, and they are in an excellent position to sustain those weight losses long term.